The content herein is for informational purposes only, not intended as medical advice, diagnosis, or treatment, and is not to be substituted for direct advice from your doctor.
Today's LymphCast program is proudly sponsored by VitaSupport MD, the makers of Vein Formula 1000 and Lymphatic Formula 1000. These MPFF-based nutraceuticals are backed by science and recommended by doctors specializing in venous and lymphatic disorders. Visit VitaSupportMD.com to learn more.
Welcome to LymphCast, the show that brings together doctors, other health professionals, and special guests to discuss lymphedema, venous disease, and other associated disorders, and what can be done if this is affecting your life. Now it's time to sit back, relax, as it's time to learn all about lymphedema, venous disease, and associated disorders on our show, LymphCast. Welcome to episode 1 of the LymphCast show, where physicians and other people will be coming in to educate you on lymphedema and other associated issues. Let's welcome our panel tonight from New Jersey, Dr. John A. Chuback, physician and surgeon. Greetings, Dr. Chuback. How are you?
I'm doing fine, Paul. Thank you. We're looking forward to this program for a long time, and I want to thank you for hosting, and I want to thank the other participants for being here with me. I know we have a couple of other participants who will be with us hopefully quite regularly who could not make it today, but definitely looking forward to this first program.
All right, and it'd be kind of a rotating cast of, not a cast of characters, but a cast of people, right?
There are a few characters, myself included.
From Scottsdale, Arizona, let's welcome in Dr. Monika Glovitzky. Good morning, good afternoon, good evening, Dr. Glovitzky.
Good afternoon. I'm a very proud representative of the LymphCast family, just starting life. And I'm looking forward to have this adventure with all of you.
All right, very good. And our last panelist for this show from Santa Monica, California, Dr. Emily Eicher. Greetings, Dr. Eicher. How are you?
Thank you very much. I'm very honored to be part of this wonderful family of LymphCast, and thank you, Dr. John Chuback, for this brilliant idea to educate not only the patients, but mainly physicians about lymphatic disorders.
All right, very good. Dr. Chuback, why don't we start with you? We'll go around the table, and each person just describes their background. Tell us all about yourself and how you got basically from birth to this point in life and what you're going to bring to the table on the LymphCast. Dr. Chuback.
Sure. I'll give you the briefest version I can. Starting from birth, born here in northern New Jersey, just outside of New York City, in the shadows of New York City. My father was a physician, my mother was a nurse, and I was raised in a medical family, encouraged to pursue a career in medicine. Long story short, I was successful in that pursuit and became a cardiac surgeon. I spent the first 5 or 6 years in my practice doing only open heart surgery, strictly cardiac surgery. And then with the changes that were occurring in medicine, with a shift toward minimally invasive procedures and a shift away from what I call maximally invasive procedures, which open heart surgery certainly was, I found quite accidentally the field of venous medicine, office-based venous medicine, specifically for superficial disease and chronic venous insufficiency for patients with varicose veins, etc. That was around the year 2006, 5 or 6. I was still doing open heart surgery at that time, but became aware of this field as my partner and I were looking to expand our cardiovascular practice in terms of volume, because the volume in open heart was dramatically reduced by the advent of interventional cardiology, angioplasty and stenting, et cetera, which is a different group of physicians. Those are interventional cardiologists, not cardiac surgeons. So I became interested in this field, went for some training, and pursued the field as just a part of what I was doing initially for a number of years. But over that course of maybe 3 to 4 years, the practice became so robust and so active that I slowly but surely ratcheted back all of the cardiac work that I was doing, and also major arterial work that I was doing in the hospital, general thoracic surgery. And all of that went by the wayside, and I became a full-time office-based vein practitioner. With that, I really began to get a new education in the world of the lymphatic system, lymphatic flow, lymphatic pathology, lymphatic problems. And that has been an eye-opener. Now, the vast majority of my venous career has been focused on venous disease. But in the last several years, for various reasons, I've become more and more aware of lymphatic pathology, disorders, and problems. And I've had the good fortune to meet Dr. Glovitzky, Monica Glovitzky, and Dr. Emily Eicher, as well as Dr. Mark Melin, who will be on our program, and some others who are real trailblazers and pioneers in the field of lymphatic disorders. And I have been getting an education largely through them, through our personal relationships and discussions. And I think it's a remarkably important area of medicine, and largely, greatly misunderstood and neglected. There's a tremendous amount of ignorance in the medical community amongst physicians about lymphatic disorders, about the lymphatic systems, truths and myths, and in many cases, just a complete absence of knowledge. And so in more recent times, in the last 6 months or so, as my relationship with Dr. Levitsky and Dr. Iker has become, and Dr. Melin, more and more profound, and we've had more conversations, more discussions, and so forth, it hit me one day that this really calls for a program like this, where we can bring world-class experts together to educate, hopefully, other medical professionals, as well as the general public, the lay public, and patients who are suffering from these disorders, whom in many cases are not even aware of what their proper diagnosis is, and are walking around confused, misguided, misinformed, mistreated, misdiagnosed, et cetera, et cetera, et cetera. So I felt it was high time we had a program like this. It's a labor of love, certainly. And as a cardiovascular surgeon whose focus has really been on venous disease, I consider myself as much a student in this area at this time as I do an expert. So I am looking forward to getting a robust education along with everyone else. So that's 50 years in a nutshell. Took me a little longer than I hoped, but that's where we're starting, and I really look forward to this.
Couple quick questions for you, Dr. Chuback, before we go around the panel. You mentioned something that people oftentimes have this, but they don't know that they have it. What are some of the symptoms that could trigger a thought that they might have it if they're experiencing those now?
Well, we're going to get deeply into that subject, but on a very, very superficial level, I would say the biggest issue is swelling. Swelling of any kind is abnormal, it's pathological, with the exception of mild swelling at the end of a long day, standing, etc. But any persistent or pronounced, recognizable, symptomatic swelling should be addressed, and an underlying diagnosis should be made. And the diagnoses are varied from heart failure and heart dysfunction to kidney dysfunction to dietary abnormalities with high salt diets and so forth, but also venous insufficiency, also post-traumatic, also post-surgical, also congenital problems. So we're going to go through a tremendous number of entities that could be causing swelling, but it's really the telltale sign that something is awry with the lymphatic system. Either it's insufficient in its function or it's being somehow overwhelmed and being asked to do something that it's incapable of doing because there is too much fluid overload. When the patient is experiencing swelling, especially certain sorts of swelling with typical signs of swelling of the dorsum of the foot, the top of the foot, squaring of the toes, loss of the normal contour of the shape of the leg, etc., that's one very important set of signs. The other thing that we're going to get into deeply in this show, where I'm going to get a real education, and Dr. Iker particularly, I think, is going to lead that discussion, is the person who has lipedema or lipedema, where there are abnormal deposits of fatty tissue and an irregular morphology to particularly the lower body, the buttock area, the thighs, the hips, the lower leg, etc., but can also affect every area of the body and the upper extremities as well. So we have a long journey together, a lot to learn, but the telltale signs that someone is probably thinking to themselves, why do I look this way? Why am I so swollen? Why am I shaped the way that I'm shaped? And my mother is shaped this way, or my aunt is shaped this way, and so on and so forth, because these are, in many cases, congenital problems that can be passed in families. So if you say, why does my family look this way and everybody else in the neighborhood doesn't appear to have our proportions, etc., that's the time to go to a specialist, an expert, and hopefully get a proper diagnosis and then a proper treatment plan and intervention that can hopefully prevent progression and reverse whatever state of pathology there is at the time.
I have a couple more questions for you, but I will save those because we want to meet the
Please
rest.
do, yes.
We want to meet the rest of the panel here and find out about their background. From Scottsdale, Arizona, we already met her, Dr. Monika Gloviczki. And Dr. Glovitzky, please tell us all about yourself, your background, and how you got to where you are today doing what you do.
Well, long story that I will try to squeeze in a couple of minutes. I was born in the communist Poland, and my father was an artist, painter, and a graphic artist. My mother was a specialist of Polish language that was working as an editor of the Polish dictionary. And the other particular point, I was born with a malformation. So whole first part of my life was the past of the sick child with all the not very nice contacts with the medical medical teams, because I was, of course, the child is not aware what is happening truly, and you feel like a victim of the physician who are like giving all this treatment, and well, of course, it stays with you in a way. But besides that, well, my family was a pretty happy family, and I never was thinking of being a child about the future in the medical field, for obvious reason. And for the reason that I was rather shy. I never considered myself smart enough, good enough to take this enormous challenge of medical studies. But in one moment, I was convinced by my sister, and I launched myself. And strangely enough, I went through the very competitive exam to start medical studies and started in the medical school in Warsaw. And then, unfortunately, in Poland, we had the martial law installed by General Jaruzelski, and I defected with my sister. We went to Italy, then I went to France, and she went to the United States. And in France, of course, that was a new chapter, new challenge. Again, with the medical school, which is very competitive and very hard. But I made it. I knew that I wanted to do it, and I did it. And not only I knew that I wanted to do it, but I knew that I'm particularly interested by research. And this is a little bit what I'm representing in this team, because I oriented all my professional career towards research. And after my studies, I joined the private laboratory, and was working in the vascular research, and specifically in the venous and lymphatic diseases research, oriented towards the discoveries of the new medications, but also working with the existing medications. And that's a little bit my short story. In the middle of that, venous and lymphatic disorders were also a little bit like my love story, because I met my husband during one of the conferences that we attended together, and specifically that was a consensus meeting on venous disorders organized by Professor Nicolaides in the monastery, which was very, very nice and curious place to meet the future husband.
That's right.
And that publication appeared later in the circulation, so we worked well, I have to say. Yeah. Well, after that meeting, we were just dating in one moment for some time, and obviously I decided to join the United States, where I was at Mayo Clinic for several years, and now we are both retired, and we decided that that's enough of winter in Rochester, Minnesota, and we moved to Scottsdale.
Okay, well, very good. Pretty good, exciting story, too. A long journey, but we're glad you're here. Let's go down over west now to Santa Monica, California. Dr. Emily Eicher, tell us all about yourself, your background, and how you got to this point with what you're doing right now.
Well, hi to everybody. And again, I'm very honored to be part of this fantastic team. I also come from former communist Czechoslovakia, and the country split in 1991, I believe. So I am from the eastern part, from Slovakia, from capital of Slovakia, which is Bratislava. I was raised in a very loving family. My father was very incredible human being, and he was fine cabinet maker. My mom was a secretary, and according to my mom's wishes, I was supposed to be a secretary, but I have to tell you, I had nightmares about sitting at the desk and being secretary. And even now, when I answer the phone and put someone on hold, I disconnect not knowingly. So Mom, forgive me about that. But since early childhood, I always wanted to be a doctor. And I was fascinated by the anatomy books and so on. And after the Russian invasion, which later on it was classified as liberation, I decided that Czechoslovakia would not be a place for me to study. And so I also defected. I think like Monica, we were brave, young, naive and whatnot. And I went through camp for refugees in Germany and ended up in the United States. And it was interesting because they gave us choices to go to either Australia, Canada, or Germany or United States. And I thought Australia, it was too far and too flat. And Canada was too cold and I had no money and I had only one light jacket on me. And so I came to the United States, and I am grateful that I made that decision. However, when in my first year in the United States, I was working in a sweatshop. I did develop swelling of my right lower extremity, which led to lymphedema diagnosis, lymphoma diagnosis, and I was treated with surgery and cobalt treatments. In the meantime, I went through undergraduate in UCLA, and unfortunately, the lymphoma returned on my left inguinal area, and so I was treated with chemotherapy after surgery, radiation treatments, and so on. And then I went to medical school. In my residency in surgery, which was my first choice, I developed acute onset of swelling and exquisite pain in the right lower extremity. And I remember that was during a simple arthroscopic surgery, and I felt like blood was rushing down my leg. And so that was the onset of my lymphedema involving right lower extremity. In early 80s, nobody knew anything about lymphedema. So with a swollen and little painful leg, I then branched to physical medicine and rehab. And even then there was not much about lymphatic disorders, maybe a little bit about lymphedema of upper extremity after breast cancer. So upon completion of New York Medical College, I came to Santa Monica, which was nice and warm. And I stumbled upon a French physical therapist who brought Professor Leduc, one of the authorities, and a person who established European group of lymphology. And he came to give a presentation as well as the workshop. And finally, I felt like somebody knows what they are talking about, and I could identify my lymphedema and lymphatic problems with that. So I can say that lymphatic disorders selected me. So I am an expert patient first. And whatever I tried on me first, then if it worked, then I applied that to the patient's population. Mm-hmm. And in 95, I established a lymphedema center in Santa Monica, where I diagnose and treat lymphatic disorders conservatively. If needed, then we triage patients for surgical interventions to different doctors in the United States or abroad. And I love what I do. I identify with the lymphatic disorder. And as Dr. Chuback already said, we see now a lot of patients with not only lymphatic disorders in terms of lymphedema of upper extremity, lower extremity, etc., but also lipid disorders such as lipedema, or now Derkum's disease or Madelung's disease. And so I can diagnose there by using the ultrasound as well as the clinical presentation and clinical examination. And again, I am so happy to do what I do. I would never change my choice of selection of coming to the United States, studying what I wanted to do. And in my medical school in St. George's University, I bought a plaque, and there is on the wall, it says, "Follow your dream."
Mm-hmm. I think that's a great story. The fact that you can tell your patients, "Hey, this worked on me. Now I'm going to try it on you." It's
Yes.
that's the way to go. Dr. Chuback, let me go back to you. Just out of curiosity, how do patients find their way to you? Are they diagnosed by another physician who then refers them to you, or do they just, the family physician might say, "I don't know what's going on, but if a lot of swelling, I'm going to refer you to Dr. Chuback," or how does all that take place?
I'd say generally there's a combination of three avenues. One is doctor referrals. I've been in practice for 20 years, and I've built a strong network of referring physicians in northern New Jersey over several large, highly populated counties, going back to the days that I was doing open heart surgery and building those relationships. So physician referrals is one way. I think that probably the primary way at this point in my career is patient-to-patient referral. When patients recognize that other patients look the same way that they do or did, they refer patients to the practice. And then a third way is through active, for lack of a better word, advertising and promotion of the practice through print media and also through internet and social media, website, etc. And the reason I say lack of a better term, it is advertising, of course, but the real motivation behind that is education. We're trying to educate the public and show them, do you look like this? Do you feel like this? Do you have these signs and symptoms? Because if so, there is help. So that would be the third avenue. And people, fortunately, many find their way to our center each year.
Okay, so I mean, sometimes they might come in and they don't really know. Well, obviously, they might not know what they have, but they just saw the ad and they said, I feel swollen, I have this pain, I'm going to give this a shot. It might be lymphedema, it might be some venous thing, or so I'm sure you see that quite a bit, right?
Definitely, I would say the vast majority of the patients that we see are misdiagnosed. The vast majority of people that we see with lymphedema are not given a diagnosis and told that there's nothing that can be done. Mm-hmm. Many people are told there's nothing that can be done, and that maybe elevating their legs at night would be helpful. But certainly nobody's is getting, or very few people are getting, a proper diagnosis of lymphedema in the community and being sent, except for those people with whom I've been working now for more than 15 years, and we have a steady stream of patients coming now with the proper diagnosis because those doctors are aware of what we do and they've had a lot of feedback and interaction with us over the years. But many people come from their primary care doctor, not referred by their primary care doctor, having either seen my practice in an advertisement or a friend or associate telling them there is this doctor who deals with patients with swelling and vein problems, and maybe, I saw him, my husband saw him, my sister saw him, maybe you should go and see him. So typically they come without a proper diagnosis, looking for one, and most times they're absolutely astonished to find out that what they have actually has a name, has a treatment, has a cause, et cetera, et cetera. It's actually quite remarkable that there's still so much I would say ignorance in the medical community about this group of disorders. And it is a group, and it is a large group with various causes and various manifestations and various treatments. But generally speaking, physicians in the United States are quite very much in the dark about this. And that's a huge part of this program. The reason we're here, not only to reach patients and hopefully provide them with information and avenues to help, but also healthcare practitioners, not just doctors. I won't just single out doctors, nurses, technicians, ultrasound technologists, therapists, physical therapists, massage therapists, et cetera, et cetera. There is a subset who is very knowledgeable, highly knowledgeable, but I would still say the vast majority are completely in the dark with regard to this.
Mm-hmm. Well, as a non-physician, I can tell you absolutely, based on my discussions with you, I've managed to help two people I know fairly well. They've had swelling of this or that forever. And I said, well, you might want to try this. And they found a physician in their area, not New Jersey, unfortunately. They would have come to you. And, basically, that's exactly what it was. Their doctor had no clue. They had no clue. They'd been suffering for years. So you're doing some good already, even outside of New Jersey, which is great news. And the more we do these shows, the more people will understand, right?
I certainly hope so. And I do believe that they will. And the message will get out. And each of us has to do what we can do. We have societies that we belong to, the American Venous and Lymphatic Society, and of course the Society for Vascular Surgery, and we're not the only ones. The American Venous Forum, et cetera, are sort of blowing the bugle and sounding the horn, but those groups are still relatively small groups in comparison to, let's say, the army of primary care physicians who are either in general practice, family practice, internal medicine, et cetera, et cetera. We're still kind of a very small fraction of the overall medical community. And even our area of vascular disease is a fragment of vascular disease. And in many ways, we're outsiders, so to speak, in this world of venous and lymphatic medicine. So there's much work to be done, and the more voices, the better, I think.
Yeah. Let me go to Dr. Eicher for a few moments. Dr. Eicher, you mentioned, if I understood it correctly, surgery is the last step. You try a lot of other things first, and if that doesn't work, then you refer them for surgery. What are some of the treatments that you provide or that can be provided, maybe starting with the basics to treat when patients come to you?
Well, the most important is to diagnose patient properly, whether the patient does have, if there is any swelling, you have to diagnose whether it's lymphatic origin or something else. And once we know it's a lymphatic origin and patient has lymphedema, we can confirm the lymphatic problem with lymphocyntigraphy or ultrasound. Lymphocyntigraphy is a nuclear medicine study which shows us the rate of flow of the lymphatic system and also the anatomy, the presence of the lymph nodes in the either axillary area in the arms, for the arm lymphedema, or inguinal area or others. So that is important when the diagnosis is not very clear, and also to guide us with the treatment. And with ultrasound, it's a simple tool where we can do with ultrasound imaging to see the subcutaneous space in subcutaneous fascia, including the dermis. Once we diagnose the patient, then we can guide the patient with appropriate conservative management. And what would be the conservative management? It is the skin care and teach patient about what is lymphedema and how to deal with lymphedema on daily basis. Within the clinic, we do manual lymph drainage, which is a hands-on stimulation of the subcutaneous space, and with hope of reducing some subcutaneous volume, and also promote a rate of flow of the lymphatic system. With that, I combined it with intermittent compression pump treatment, and we tend to have very good results with that. If the patient is satisfied, then we fit the patient with compression garment that should be worn during the day. If necessary, there are all kinds of compression garments for the night, or resting garments. And then we guide the patient what kind of compression garment the patient should have during the daily basis, on daily basis. If the patient fails to respond to conservative management, we do have now surgical options. And for the lymphatic system, we have lymph to vein anastomosis, where there is a bridging of the lymph vessel. And the lymph vessel is very tiny, size of a hair, but it can be bridged to the venous circulation. And if not, then if the patient is not a candidate for that approach, then we have a transfer of the lymph node from one area of the patient's body to another. And usually the lymph nodes from the omentum are taken and used for either lower extremities or upper extremities. With that, patients tend to have very good results. The question is always, and it's interesting when the patient discovers that A, they do have lymphedema, B, that they will have a surgery. And the question from patient is, can this be fixed? So I would say no, it can be improved and not fixed, because once it's already so significantly impaired, the fixing the lymphatic system is not optimal at this point yet. Hopefully in the future, we will have more studies done, more research where further improvement can be done. And then in terms of lipedema, we have similar treatments of the decongestive therapy or manual lymph drainage, compression pump treatments, and other modalities.
Okay, so overall, there's really no cure for it, but there's a series of treatments. You can make it better, you can modify it, and then it's a matter of patient care, whether it's medication or surgery. That's kind of how physicians look at this.
That's true. We recently had a patient, and she had not only primary lymphedema in right lower extremity, but also lipedema, and her right lower extremity was 40% larger than the uninvolved left lower extremity. And she failed to respond to conservative management. With the surgical approach, with the lymph node transfer, she 6 months later improved from 40% to residual 5%, which was phenomenal improvement. And the patient was very happy. She could sit down on the floor and play with her little boy. And she was happy because she was much more functional than before the surgery.
Yeah. All right. Let's go to Dr. Monika Glovitzky. In all of your research, what are some of the things you uncovered, or some of the things that you found that would help physicians like Dr. Iker, Dr. Chuback perform in their offices with their patients? What are some of the elements you uncovered?
So as far as research, there is a lot of work ongoing, looking for the optimal medical treatment with some drugs. We do have already the supplements such as MPFF that improve the lymphatic drainage, to improve the contraction of the lymphatics and speed of the lymph flow. So that's already something, and it's pretty efficient. And it was proven not only in the experimental studies with the some in vivo models of edema, but also in patients with the lymphedema after breast cancer. And it was really significantly higher speed of the lymphatic flow found in this patient with severe lymphedema and found on the lymphocyntigraphy. So that is already something. There is a lot of search ongoing to have more efficient drugs, and certainly the molecules that would be qualifying for the FDA approval. So this is open field. A lot of people are working on it. of course, as with the all drug research, it faces a lot of question because of you not only have to be efficient enough to have the advantage to introduce such a medication, but this medication has to be safe. And this is huge issue, because in one moment, for example, there was a discovery showing that benzopyrons, some of benzopyrons are good in lymphedema treatment, but then after it was withdrawn because of the side effects. So it's really very delicate point, and until the drug is proven to be completely safe, and especially in the situation of the chronic treatment, you cannot introduce it on the market.
Okay, and just out of curiosity, through your research, did you find, or has it become your opinion, that these issues have been around since the beginning of time, or have they come about because of our environment, our society, where we just eat the wrong foods and don't exercise, or anything like that? Has this been around since the beginning, or is it fairly new to us?
Well, edema was with us since the beginning of the times. You have, in one moment we were talking, do you have this drawings on the in the caves? And there is one drawing in the really ancient cave showing like the compression over the leg of this little human figures. Wow. So certainly it was as ancient and as the human being. And I think that especially that one of the origin of lymphedema is the venous disease. And venous disease is practically related to gravitation. And it's probably as old as we are standing on both legs, because of course our venous system has to face the situation that you have to bring the blood from the very down of our body up to the heart. And this is not an easy job.
Okay. Yeah, this might seem like a silly question, but you just mentioned standing on two legs. Is this something then that like dogs or cats or cows don't have to deal with? It's strictly a human condition?
No, it's a human. Well, the animals will have the edema related to traumatized the situation, or they can have a cancer blocking the blood return, and then you can induce the edema in the animals, like we were having in the in our lab the model of edema with the arteriovenous fistula, and this huge amount of blood going directly to the vein with the venous hypertension was provoking the edema of the animal leg. But spontaneously, there is no venous disease such you see in human beings, chronic venous disorders. There's not such a trouble in animals.
Okay. Well, Dr. Chuback, let me turn it back to you. Do you have anything to add to everything you've heard so far? Would you like to ask one of these ladies a question? Let me turn it over to you for a bit.
Yeah, I would add a couple of things. One is that as a board certified general surgeon and cardiovascular surgeon, I had a very lengthy and I think quality surgical education. And many of the procedures that Dr. Iker is referring to in the contemporary approach, kind of a heroic approach surgically to offering patients a surgical, not solution, but clinical addition to their overall care. These operations to which she's referring, I've never been personally privy to any of them, to give you a sense of how rare they really are. And I was training in huge university hospitals, where textbooks were being written and world famous surgeons teaching, really at the cutting edge of vascular surgery and general and cardiovascular surgery and so forth. I had never seen any of these procedures performed. So they really are not only cutting edge, but in a very, very tiny set of hands right now surgically. It's a fascinating subject. One of the things I don't think Dr. Eicher mentioned was the surgical approach of which she's very knowledgeable in, again, much more so than I am at this point, in the liposuction approach, especially for patients with lipid disorders and things like lymphedema, which, again, in my surgical training days, was considered very, very high risk, and may still be considered to be of some risk in making the patient worse, having problems with infection, et cetera, et cetera. So liposuction, which seems like such a obvious answer to some of these disfiguring lipedema issues, can be fraught with its own set of complications. So it has to be done in the hands of someone who is really knowledgeable, highly experienced. And I look forward to learning more about that, is what I want to say on this whole subject of lymphovenous anastomosis, lymph node transfer, and even liposuction in the right clinical circumstances. But I just wanted to bring out how few surgeons are expert in any of these particular operations. So I'd love to hear Dr. Eicher's thoughts on that and Dr. Glovitzky's thoughts, because she is, of course, married to an internationally renowned vascular surgeon who has done some of this work, I know, and has certainly been privy to more of it than I have. So I'd love to hear their thoughts on both of those things. Okay,
Dr. Eicher, why don't you take it from there?
Well, in early 80s, we had Charles' procedure for lymphedema patients. And that was just complete debulking circumferentially in lower extremities. And it turned out to be pretty much unsightly and many times catastrophic for the patient if they developed infection following this kind of horrendous surgical approach. And I remember I was at one of my first European meetings in Paris when Dr. Becker, a female plastic surgeon from France, came up with the idea of lymph node transfer. And this was, I would say, early 90s. That only tells you how long I have been doing this. And just the other day, I had a patient and she said, I saw you 25 years ago. I went like, not possible. But anyhow, so she came up with the idea of lymph node transfer. And at that time, everybody was saying, well, crazy woman, what do you say? And she was one of the pioneers who started with this. And then Dr. Håkan Brorsson from Sweden, he started to do liposuction for lymphedema. And again, initially, everybody was very conservative about this approach. And now he's doing it pretty much on a daily basis. Yes, indeed, we have very few surgeons who are now well-trained, and they are doing the lymph to vein anastomosis, which is highly specialized microscopic surgery. And we have only handful of surgeons in the United States who were trained by his the lymphatic guru, Dr. Ming Cheng, I believe he's from Taiwan, and he was training few of our surgeons to do these procedures, along with the lymph node transfers. So we are blessed to have in the past decade and so few highly specialized surgeons who are focusing on lymphatic disorders as well as lymphedema surgeries. And going back to 20-something years ago, 30 years ago, no, we didn't have anything. It was the Charles procedure. And unfortunately, I've seen quite a few patients who did have Charles procedure, and the surgical outcome was not artistically pleasing, and the same for the patient. Those patients end up with a lot of scar tissue and further lymphatic problems.
Oh, wow. So I'm guessing when you went to medical school, you didn't see this either during your training. It wasn't discussed at all?
In medical school, as Dr. Chuback pointed out, we didn't have much about lymphatic disorders, maybe one page. Everything was focused on arterial and venous problems and not lymphatic problems. And I think with the onset of breast cancer, and that was when I did my surgical training, even the treatment for breast cancer at that time were completely different. So I am very happy to live today to witness and to experience these beautiful outcomes, much more artistically pleasing, and also for the patients who are now with improvement of mobility and pain reduction after these very unique surgical techniques.
All right. Dr. Glovitzky, would you like to weigh in on what you just heard from Dr. Chuback and Dr. Eicher?
Well, yes, I think I have at home echoes of all these issues, as actually I'm married to somebody who in 70s was among the first doing the lymphovenous anastomosis. And I was a very good friend, of course, and I did some research with Professor Olszewski, who was truly a giant in the lymphatic disorders treatment and the research. So that's for sure that is a huge issue. That was a treatment. All these treatments were known in the 80s or 90s, but it requires a particular skills, because it's a microscopic surgery. So actually there's a couple of centers in Europe doing that even now, because it's very tedious. It's difficult to find the patients with the right indications. I'm sure that once we really invite my husband, Peter Gloviczki, he will explain it much better. But certainly, it's not an easy surgery. And the same with the specific liposuction, because it's not like every liposuction. It has some particularities, and you have to follow the very special procedure. Otherwise, the patients are in trouble. Mm-hmm. The Charles procedure was just like criminal almost for me, because when I have seen the patients with the scar, with the invalidity after those, it's that was a very bad idea, very, very bad idea. So certainly there is a place for surgery. I think that will develop. The issue is that it's very complicated. Few people are wanting to deal with, because it's so complex, and it really depends on your microscopic the surgery skills.
All right.
That's what I have.
Okay, very good. Let's go back to Dr. Chuback. Dr. Chuback, your thoughts?
Yeah, well, I find that all very, very informative and fascinating and interesting. And I'd like to, obviously, in the course of this program, learn more and more about all of those techniques and bring experts on to educate us and discuss and open our horizons and increase our awareness. One of the things as a physician in general, the Hippocratic Oath teaches us, rule number one is do no harm. So as a surgeon particularly, this is a huge, what is the right word? This is a huge responsibility that we're given when you use your hands, surgical instruments, to basically invade another person's physical being through any kind of surgery. When you cut a patient, when you enter a patient's body cavity, when you manipulate their body in any way, this is a huge responsibility. Mm-hmm. And the last thing we ever want to do is hurt a patient, take a patient who is sick and make them worse. This is a devastating situation for any practicing surgeon who has enough experience. This is the worst day that you can ever have at the office, so to speak, in the operating room. So we are very hesitant as surgeons and physicians in general, but certainly surgeons, highly sensitive to never hurting a patient in an effort to make them better. Right. And that's a very fine line. So when you talk about the Charles procedure, which was a failed procedure, the one thing that I can say is that we've seen many failed procedures in the course of surgical history because the need appeared to be so great. So sometimes surgeons historically, surgical educators, surgical leaders, pioneers have been desperate to try something for people who are in desperate circumstances. So it can be a trap. And those efforts lead us to knowing what works and what doesn't, what's right and what's wrong, what becomes a surgical disaster and what becomes the next thing that moves surgery forward. So unfortunately, surgery does have a sort of skeletons closet, or a closet full of skeletons of such procedures, and fortunately they come and go. But I can understand why surgeons in the past have tried certain things out of desperation to try to help patients. Mm-hmm. And it takes courage. For example, the surgeons who started doing liposuction, as Dr. Iker pointed out, I mean, the response of many other surgeons was quite, horror, quite frankly. I mean, really outraged that, you're going to hurt these people and make them worse. So, but it takes a certain personality, a certain subset of surgical educators and pioneers to push the limits of what we know, what we believe, and what we think we can do in order for change to occur. Sometimes we go forward, sometimes we go backward, but it does take courage in the hands of some of these courageous pioneers. As she mentioned, the female surgeon, Dr. Beckett from France, that took courage. I mean, to say we're going to open somebody's abdomen and remove omentum to then put in, let's say, the groin or something. This is a radical concept. It doesn't come, well accepted initially, but it doesn't make it wrong. So these are all fascinating ideas. I can't wait to learn more about all of them as we bring more experts in as guests. And those were kind of my closing thoughts on our initial look at surgical management of these diseases. But I know we're going to get much further into it in the future.
Okay. Well, thank you very much. Dr. Eicher, your closing thoughts?
Well, I am looking forward to our discussions in the future in talk about all lymphatic disorders and educate our audience, not only patients, but mainly our colleagues.
Right. Okay.
Frequently, I see patients who are coming with lymphedema and they are on high doses of Lasix, a water pill. And that is not the answer that we should see. And with our education, I think the patients will have better care.
All right. Well, thank you very much. And Dr. Glovitzky, your final thoughts.
I think it's such a great idea to have the platform to discuss it from the several angles, from the research point of view, patient point of view, physician point of view. And I'm so grateful for the leadership of Dr. Chuback, who initiated this project. And I'm looking forward for the future, bright future of LymphCasts.
All right. Well, thank you very much. That brings us to the close of episode 1 of LymphCast. Stay tuned for the next show, which will obviously be number 2. And Dr. Glovitzky, thank you very much, and we will see you next time. And Dr. Iker, same thing from Santa Monica, California. Thank you, and we'll see you next time.
Thank you.
And Dr. Chuback from New Jersey, physician surgeon. Thank you, sir, for putting this all together and participating, of course. We'll see you next time as well.
Thank you, Paul. Looking forward to it.
All right, till we see you next time. This has been LymphCast, episode number 1.